I introduced myself in the intro, but not all of you may have been there, but my name is Maria Monroe DeVita, and I co-direct the University of Washington Spirit Lab and direct the Washington State Center of Excellence in Early Psychosis. I also lead our implementation team, which provides training and support to the New Journeys teams across Washington State. I'm going to introduce our other two presenters briefly, and then they're going to have a chance to talk to you more about their role and tell you more about themselves. But I'm excited to have Catherine LaBranche. She's a program director in family education clinician at Behavioral Health Resources, and Kyle Payne, who is a former supported deployment in education or C specialist at Valley Cities, and he now works with us at University of Washington as a trainer for our C specialists. So let's get into today's quick agenda, objectives, sorry, which is my agenda. So today we're going to provide a summary of treatment for first episode psychosis. And again, the kind of name of that treatment or model is coordinated specialty care, or CSC. We'll talk about the specific model of CSC in Washington State and introduce the New Journeys program. We'll talk about the New Journeys admission criteria, roles and services. Also, as I said earlier, an opportunity to hear more about two of those roles with Kyle and Catherine. Catherine will talk about the family education role, and Kyle will talk about the supported employment and education role. And then hopefully we'll have a chance to hear from you. What are your questions for today so that we can answer them, because that's a big goal of getting you all together today. So first, I'm going to start us off with just better understanding the problem we face today on this particular topic. So each year, we know that approximately 100,000 young people experience a first episode of psychosis. Many of these individuals and families go without care for long periods of time. For some of you, this may resonate quite a bit. In the US, the average duration of untreated psychosis, or DUP, as we'll continue to refer to it, is more than 2 years. This is in spite of the fact that the World Health Organization suggests that specialty care for first episode psychosis start within 3 months of illness onset. And we're just not getting folks as early as 3 months in. So other than the obvious issues with helping folks early, here's why that's a serious problem. Multiple studies suggest that longer DUP contributes to more frequent relapse, a longer course of illness, and more profound disability. And while it's a relatively low prevalence disorder, the burden of disease for psychosis and schizophrenia spectrum disorders in particular is substantial. Psychosis is associated with high disability, accounting for a significant portion of Social Security expenditures, with enormous personal and societal loss. People who experience psychotic disorders are also at higher risk of poor long-term health outcomes and decreased life expectancy. And suicide rates are also higher, as are rates of homelessness and incarceration in this population. Okay, so that's the bad news. And I said this earlier when we did the opening for today. I'm going to take a deep breath here. And that is to say there is hope. That's why we're here. So this is when we switch to the good news, and I hope for the rest of this presentation to be all about good news. The good news is partially rooted in a treatment model called coordinated specialty care, or CSC. And that term, coordinated specialty care, was first coined by the National Institute of Mental Health to describe this evidence-based model for treating first episode psychosis. It's based on models originally implemented in other countries. Many of those countries are those that had a form of universal health care, like Australia, Britain, Canada, Scandinavian countries. And it leverages a multidisciplinary, multi-component service approach to first episode treatment. Research conducted on coordinated specialty care worldwide shows significantly positive outcomes in the areas you see here. So a lot of those listed, and I know Dr. Melton talked about that as well. And this is compared to treatment as usual that's offered in the community. And again, the shorter the duration of untreated psychosis, the better the outcome. And as I said earlier, and also vice versa, the longer the DUP, the tougher the outcomes. So this should look a little familiar. I know Dr. Melton shared a similar model of coordinated specialty care. As he mentioned, there are several models of CSC out there. Some of you may have heard of the Navigate model, which is what our teams here in Washington State are based on, our New Journeys teams. There's also the ESER program just to the south of us in Oregon, which Dr. Melton is affiliated and has been affiliated with, and in some other states, and then On Track or On Track New York, just to name a few of those. While they have different names, they typically have common treatment elements, and many of those are listed right here. They include low-dose select antipsychotic medications, case management, evidence-based psychotherapy, typically provided individually, but sometimes they're also offered in groups, supported employment and education, which we'll hear more about today, peer support services provided by a team member with their own lived experience with mental illness, who then can offer that unique perspective and help the person in services to navigate and self-advocate for themselves. And then family education and support, which Catherine will be talking about today. And again, you can imagine many of you are family members or natural supports here on today's event. And we do this because we know that the vast majority of people are diagnosed in their youth or during young adulthood. They're also often living at home with their loved ones, and they're not actually at an appointment most of the time. And so we need to help our families in supporting them and understanding kind of what to do when their loved one is at home and how to best support them in their life outside of care. And then lastly, community outreach and education. That's really what we're doing today and next week. It's such an important feature of the New Journeys model because it serves to not only generate referrals to the program and potentially to other related services in the community, but, you know, like today, it's also done more generally just to help the community recognize early signs and symptoms of psychosis. So I want to talk a little bit, I actually threw these slides in somewhat at the last minute because I know Dr. Melton didn't talk about them as much, and I wanted to make sure we're all on the same page about what psychosis is. Sorry, I have a little frog in my throat. Before I dig into New Journeys. So psychosis is the condition of the mind described as involving a loss of contact with reality. And here are some of those common symptoms like hallucinations. So, you know, that would involve hearing or seeing or feeling or smelling something that others do not experience, like hearing a voice that others can't hear, or delusions, which are having a strong belief that is firmly held in spite of the evidence to the contrary. You know, an example might be feeling convinced from the way that cars are parked outside that you're being watched by someone. Confused thinking and other cognitive difficulties. Difficulty with thinking clearly and expressing oneself clearly, or problems with concentration, memory, and reasoning. Maybe sentences are unclear or don't make sense, or thoughts seem to speed up or slow down, or the person's easily distractible. Sometimes people talk about it like it's like dreaming while you're awake. And psychosis affects about 3 out of every 100 people. They will experience psychosis, at least one psychotic episode in their lifetime, and the onset is often in the later teens to young adulthood. And we'll talk a little bit about the specific inclusion or admission criteria for the New Journeys team in a little bit. The most common diagnoses we see, and we'll talk again about the admission criteria, are these three: schizophreniform disorder, schizophrenia, and schizoaffective. You'll notice that the symptoms are identical for the first two. And the timing is somewhat similar, but the difference is that for schizophreniform, the symptoms last at least 1 month and they cause significant impairment, but then they completely subside before 6 months, whereas for schizophrenia, they must persist for at least 6 months. And then schizoaffective disorder is different in that there's a mood component within the context of psychosis, and that too must persist at least 6 months. Here is a list of some of those most common signs of emerging psychosis. And as I share this slide and the one after it, you know, for those of you with teenagers at home, some of these feel a little bit like, is this the teen years? Is this just what we're dealing with? Maybe, spending a little more time in their room, for example. So it can be really hard to sort of know what's happening. And that's why, just really being able to have a heightened awareness of what you're looking for is really key. Here's another list of additional signs of emerging psychosis. Social withdrawal, hostility, or suspiciousness. I won't read the whole list, but this is there for kind of future reference to just kind of keep a lookout for. And then where people are often first identified, I mean, some of them are you all, right? You come from these places. You may be affiliated with the education system or a youth program or a physical health provider like a pediatrician or primary care physician. And sometimes, these last four are often where we come into contact. We want to avoid that if at all possible. And that's why we're talking with you all today. But sometimes folks may be hospitalized or make it to the emergency room or other crisis or justice system involvement. And again, family and friends are often the first to notice those early warning signs and symptoms of psychosis, because you're seeing them more than anyone. All right, so I'm going to shift into then our Washington State New Journeys program. And this is a nice little diagram that kind of shows all of the different components of the model. As you can see here, all the roles I just described earlier are represented with the specifics of how we staff each role. And then just to let you know that this thing called individual resiliency training, or IRT, you're going to learn more about that in depth from an IRT provider next week. However, just to kind of let you know that this is the psychotherapy I was talking about earlier. So it's a specific type provided and uses a cognitive behavioral approach to treatment and includes strengths identification and kind of how that ties to personal recovery goals. Maybe the person wants to go back to school or have more friends. That can be worked on within the context of IRT using the CBT-informed psychotherapeutic approach. Similarly, another slight change or difference here is this role of the registered nurse. I know Ryan talked a little bit about some models do include a nurse, and ours does. So the idea here is that teams may choose to substitute a nurse care manager for all or part of the case manager staffing count within their team. And the nurse often focuses on areas such as helping to screen and identify early signs or symptoms of chronic disease, health coaching to address those needs once they are identified. So maybe focusing on, smoking, maybe reducing smoking or smoking cessation or a healthier diet or exercise. Care coordination with other providers. For example, if we see risk for type 2 diabetes, then it's that connection to endocrinology or cardiology, or just, connecting to the primary care physician or getting connected to a dentist. And then, of course, the nurse does a lot around the role in medication management, including administering long-acting injectable medications and helping to identify side effects and responses to those medications. Here is a list of who gets involved in New Journeys, our admission criteria for New Journeys. So we'll drill down on a couple of the services here in a few minutes, but here is who we serve. These admission criteria are based on those from the National Institute of Mental Health funded research initiative. It's called RAISE. Some of you may be familiar with it. Our particular model, New Journeys, is actually based on the specific model that was studied within RAISE. It's now known as the Navigate program. And in that study, they tested coordinated specialty care treatments across the US. So the list includes an age range of individuals ages 15 to 40. We see a vast majority between 15 to 25 or so. They need to be a resident of the region where services are currently available, and I'll show you where those regions are in just a minute. Symptoms must present between 1 week. So at least 1 week, they need to be experiencing those symptoms, and up to a 2-year period when they present for services. And the primary diagnosis has to be one of the following. Typically, those disorders that we call schizophrenia spectrum. Ryan mentioned earlier that delusional disorder is not always included, or other specified psychotic disorders. We do include them with New Journeys. And then psychosis needs to not be caused by substance intoxication and or withdrawal. That's not to say that we don't serve folks who are using substances or have a co-occurring substance use disorder, but just in terms of the cause or known cause of the psychosis, that would be kind of not part of the admission criteria. Psychosis also needs to not be caused by a medical condition. So sometimes we'll suggest a workup by a medical provider to kind of rule some of that out. And then we also do not include a current diagnosis or presentation of a mood disorder. So say like bipolar disorder with psychotic features, that would not be included within this model, or a pervasive developmental disorder or autism spectrum disorder, or a documented IQ less than 70. And again, these are based on those navigate criteria and the manuals and treatments that we use within New Journeys that then align with that navigate program. Most of these teams serve up to 30 clients, and next week my UW colleague Cami Peretta will be talking more about the admission criteria and referrals when we all meet up again next Tuesday. So here is where our New Journeys teams are located. We currently have 17 sites in 9 regions of Washington, and that number is growing, which we're really excited about. Cami is also going to speak next week to some of the specifics of future program expansion, and that will include some of the details too about some of our new tribal and rural pilot sites. So stay tuned for that. One thing I want to show you though that is super cool is that there is an interactive map on the event platform that shows not only where all the New Journeys teams are located, but also contact information for each. So you can find it by clicking on the New Journeys sites tab. And then you can see the map right here, which is very cool. You can click on a specific team and find their contact information and their website and where they take referrals. And then, as you can see here, if you click on New Journeys team, so it's just above New Journeys sites, on the left side of the event platform, you will also see all the teams to your right, and you can learn more about that team by clicking on the Visit tab. So for example, we've got comprehensive healthcare in Yakima, and then, hey, there they are. I love those guys. So, and a little bit about them. So it's a really kind of neat feature that will help you hopefully get to know programs in your area. So now, without further ado, I'd like to pass the baton to Catherine, who will speak to the role of the family education clinician, and Kyle Payne, who will discuss the role of the C specialist. I'll have a summary slide up as they chat and tell you about each of those, but they're going to delve in more into those roles than what's on that screen. They're going to really bring it to life for you. So we're excited to hear from them. So I think, Catherine, I've got you up first.
Yeah, thank you, Maria. And hopefully I can bring this to life. So like Maria said, I am a current family education provider in Thurston County. And I've been working with the New Journeys teams for over 5 years now in several different roles. And so now my most recent role as the family education provider. And so like Maria again had mentioned, this is kind of built on Navigate. And so we are manualized, and we have a manual that we have access to follow along and kind of give us guided support for what is helpful for someone coming into a first episode psychosis program. And so in my role, I get to work with family or anybody that the identified client identifies as family. So that could be parents, friends, roommates, whoever it is that they want to work with our team, that's who I get to work with. So it kind of looks a little bit different for everybody. But most often that is parents, because that age range usually is that young teen, a young adult age. And so they're still at home and still trying to work out what they're going to do next. And so I really work with families initially to kind of get to know them. What is the structure? What is their family like? What is the relationships like? Kind of really figuring out, okay, how are you functioning together as a family? And how has this disruption impacted everybody, because while there is the individual's experience of psychosis, that family also has their experience of that. And most often don't have a place to go talk about it because they aren't the identified client in that scenario. And so our program really focuses on having that family component and really kind of bringing in and giving them a space to share, like, okay, this is what my experience was. And then being able to get some psychoeducation about what that is, what they're seeing, the changes that they observe in their loved one, and getting to talk about it and see what are the steps that are going to help that person recover, so they can get along better together. Maybe there's conflict happening, maybe there's barriers in communication, or things that they don't understand, because oftentimes you're kind of thrown into it and you get all of this paperwork and these words that people are saying, like psychosis or schizophrenia, and not really knowing what that is, or the medication can become really complicated. And so my role is really as an education provider to give them that information, to be a sounding board, to be a place where they can ask the questions they need to ask, and then also kind of share how the team is going to wrap around their loved one, and what things we can do and what things we can't do. And hopefully set them up for success. So that way, once their loved one graduates from New Journeys, they can feel like they have all of the foundational tools and the resources to be able to continue to support their family member and the goals that they've identified. So like I said, it's really just about providing education, helping them learn the language that's being told, clarifying questions about medication, or kind of understanding, like, what is this that's happening? And then helping them to kind of, as a all together, I really like to do family meetings or do like all team meetings where we come together and we talk about like what's going well from the individual side, and then giving space for the family to continue to share any concerns or successes that they've seen with their loved one. So they know like there is progress being made. Both people are kind of doing their work to support each other. And that usually can relieve some of the tension in the home, or whatever it is that's causing conflicts, or just barriers in communication again. And so just like love to have a space where we can all come together, identify like a wellness plan, partner together. Then the individual gets to tell the family like what not to do, what's not helpful, what I'm not doing well, and what is helpful. And the family can also share like, these are the things that worry me. And should I worry about them? Or are they, like Maria had mentioned, is this just like a angsty teen? Or is this something that is related to that diagnosis or those symptoms that is something to watch out for and to call out? And so giving them the space to be able to share those openly and talk about that. And then also just, again, being a place to be someone to listen to them, to give them information. Sometimes families have to make the tough decision to have a hospitalization or get their loved one some extra support outside of the New Journeys program. And so it's really, our team is kind of helps navigate those things, wrap around them, and kind of weigh the pros and cons to making big decisions like that, to see if it is something that can be managed outside, or if it really does meet that level of need. So I think that is all that I'll share for now. And
great. All right. Thank you. And I know there was a specific question related to that role, Catherine. So we'll circle back to it here in a little bit. And I want to hear from Kyle here and sharing about the supported employment and education role.
Great, Maria. Thank you so much. And thanks for everybody attending. It's really great to see such a great turnout for a wonderful event. So I'm going to talk to you about the supported employment and education role on New Journeys. I served as a C specialist in frontier, rural, and urban communities, ranging from the west side of the state into King County. I served Valley Cities for 4 years as well. And during that time, it is really a quite a different position than some of the other ones on the coordinated specialty care teams. We do a lot of community outreach and help people get jobs, back to school, we also try to help people identify what they want. This is a person-centered treatment, so we always ask a person, what is it that you'd like to do? And no matter what they say, and no matter my opinion of it, we provide resources, wraparound care that would otherwise help them get to their stated goals. And this may just be, I want to go back to school and make friends. And so we would help them integrate back into their school environment and help them deal with the struggles and maybe some of the stigma that comes with attending school after something like this. If you're out of school for a while and those types of things happen, it's really I think a great aspect of the position to be able to aid somebody in that. In collaboration with the school counselors and faculty is really, I think, a key component in being able to serve people well. That also makes it very easy. It makes it not very easy. It makes it much easier to get access to really what the student might be struggling with. But then furthermore, an older adult, maybe somebody in their 20s that we were able to serve would just want to get back to work or want to start earning money again. And through the individual placement and support model, we know that the evidence-based practice really works. And I'll tell you from my personal experience, when you get to that point with somebody where you actually see the result of that evidence-based practice and you're able to employ it in such a way that a person is benefiting largely because of the entire team and not just because of one role. And I know Dr. Meldon had talked earlier about it was all of the things that help a person recover. And that is what we are headed towards, this recovery, and psychiatric rehabilitation is the name of the game here. But then moving forward, more about the supported education and employment specialist position. An interesting engagement would be more so that we're finding out what brings meaning to that person's life, and we're trying to cultivate hope based on that. So generally speaking, if somebody has an issue, because the illness can cause some cognitive issues, so somebody getting back to school might otherwise not be capable of performing as they once did and may need to relearn all of those skills. So we coach them through that. We help them build some of those skills. And it comes naturally with part of the coordinated specialty care model for everybody to help work on that skill with them if it's something they're struggling with. And so I always want to make sure I advocate for the team and not just the one role, because the team is really the essence of recovery here. So really moving forward with benefits counseling is also one of those things that we talk about in the C role, and that is for people who go on who are in need of SSI or SSDI. And so if they do want to work, we coach them on the benefits side and how the benefits can still be active while they work, and start to talk more about those options for them and what might work for them. But furthermore, this has just been a great opportunity to tell you more about the position, but more so about the program itself and how helpful it has been. But I also want to advocate for Catherine and her role as a family education specialist, and the role of family and support in even for the C role, because you're using natural supports, as we call them. We're utilizing them to help us essentially, if they're bringing the student to school or helping somebody get to work on time, those simple things that otherwise might impede somebody's daily life or daily living activities. We try to help manage those. So, but without moving too far into that, I think that covers pretty much a lot of the C role, maybe not all, but if you'd like to ask more questions, we have our contact information available. And I'd love to hear from anyone who has more questions about supported education and employment in Washington State. So thank you very much for having me.
Wonderful. Thank you both so much. Really appreciate it. And for those of you who are going to be joining us next week, just so you know, we'll drill down on a couple more of these roles so that you can hear from the people who were directly providing the service. Again, I think, it's one thing to have a slide deck. It's another to really hear how it comes to life from the people delivering those services directly. So thank you both for joining us. I did want to shift into, since we've got a little bit of time here, Q&A. And I mentioned earlier that there was a question about kind of working with families. And I wondered, Catherine, if you and others, I think of us that have kind of done the family education work might be able to help answer this. So the question is there, and do you recommend families filing any legal paperwork to have access to their adult child's medical information and to participate in treatment or support? And those are maybe two different questions, right? Because the access to the medical information, but then the other piece is participating in treatment or support. Although I'm sure they go hand in hand.
Yeah, I mean, I think this has come up for a number of the families that I've worked with, where they're really kind of figuring out, is this something where I should like file for power of attorney, or is this something where I should take more, I guess, legal measures to make sure that I have access to the information and what's going on in his care or that loved one's care. And so I think that it always kind of differs for families. Whatever they feel like is comfortable for them is what I always say. But I think it kind of also depends on like that person's functioning. Are they at a place where they could make decisions about medications or about, I guess, more of those like high crises oriented type things? Or are they able to kind of make decisions and also include family in those things? And I think that's a big part of my role. Because I am the program director and the family education provider, I'm that first contact. And so I talk a lot about with the individual and with the family about the importance of being able to have everybody on the same page, and being able to sign releases if that person is over 13. So that person's over 13, that client needs to sign releases for families to participate and identify who they want to know the information and what information they want to know. So a lot of times it's navigating that. Are they signing a release just for family support information, or are they signing the release so that way that family member can call and talk to the psychiatrist, or call and share concerns, or participate in appointments and things like that? And so I always lean heavily into an emphasis of the client kind of being the one who's driving the bus and helping them to see the importance of having family involved. So that way they can make that decision on their own, and it doesn't have to feel like there's someone taking more control away from them. But then they also, the family feels empowered to be able to participate and know what's happening, and share their concerns where it's needed. So it kind of differs. I think it just varies based on the family and what's most important, or how, I guess, the safety of that individual, that I would kind of think about those things. Hopefully that answers that question.
It's a complicated one. Yeah, I think you handled the nuance in that quite well. It depends. And a great question, because I think the more we can get families and natural supports involved in like most cases, that's the best thing, right? We know there are better outcomes when family and natural supports are involved. And as I said earlier, that's where they're, spending a lot more of their time is at home versus, the 1 hour a week or however much that they're coming into the clinic. So we have a lot of opportunities outside of the office. We had a question about, does your model employ SUDP or SUDPT, so substance use disorder professionals at any level? And so the answer is not explicitly. You may get an SUDP or SUDPT on staff who is in like more of a case management role, or they're dually credentialed. They might have a master's degree as well as those designations. But you bring up kind of an interesting point in that that is an area that teams often kind of face and they need to address is substance use. And while it's part of the model, it's built into some extent within the manuals for both working with families and working with individuals within IRT. That's one that we're working on. We're working on trying to kind of develop more skills and resources within these teams so that they have more capacity and resources to really work with folks who do have a co-occurring substance use disorder as well. So great question. Let's see, I'm just looking through the chat here. We have a little bit of time. Let's see. I think there was a question about, okay, how can you become a team? Which we love that question. By the way, I mentioned expansion earlier, so learning more about who's interested in doing this would be great. Let's see, are the qualifying, disqualifying factors for new journeys also applicable for C? That's an interesting question. So maybe Kyle, we can kind of tag team this. I mean, I think my understanding of the question is more that what Kyle described and what was on that slide is kind of an evidence-based practice unto itself. So he mentioned the individual placement and support model, which some people know as IPS, or some people just call it more generally supported employment. IPS is a specific model of supported employment. So there are IPS programs or supported employment programs that are not attached to a New Journeys team or not attached to, say, a PAC team or other services that are freestanding in various agencies around the state. And so if someone doesn't meet the admission criteria for New Journeys, but they want, to get a job or go back to school or something like that, the IPS model is available in some of those locations and some of the very actual agencies. And so when somebody gets referred, that's often what we do, as program directors and doing that screening is identify, okay, maybe this isn't the right program necessarily for you, but here's a different one within our agency, or here's a different one in the community, and tries to do that kind of warm handoff around making sure that they get access to it. Anything else I missed on that, Kyle? Okay.
You covered it great, Maria. Thank you so much. Yeah.
Okay, great. Let's see, there was another question at the top about admission criteria, so maybe I can answer that one really quick. If they only have symptoms for 2 weeks and don't meet criteria for diagnosis, are they still welcome to New Journeys? And right now, the criteria are based on again, that RAISE study and the Navigate model. And so as of now, they wouldn't meet criteria because the person needs to kind of have a diagnosis that is consistent with the ones that were listed earlier, mostly kind of different types of psychosis, schizophrenia, spectrum disorders, and such. And so again, that's where I think the role of the team is often, okay, where can we get that person connected up with services? And as Ryan said earlier, there are other types of models of coordinated specialty care that do have more expanded admission criteria in other places, but those aren't necessarily the specific model that we have here with the Navigate model right now. And I think we're doing this also based on identified needs in the community. So we've had quite a few folks who have met the criteria that we've already got, and then looking down the road, we'll see where we come up with in terms of expansion. Let's see, questions. I'm just going back in. Does New Journeys have programs for people over the age of 40 years old? Yeah, that's a great question. So New Journeys, I mean, I think there have been some exceptions where somebody's a little bit younger or a little bit older than the criteria ages 15 to 40. And so that's kind of handled on a individual basis. But when somebody, typically what we'll find there is that often if folks are experiencing psychosis kind of that late, there might be something else going on with that individual. And so Often they're not meeting criteria for New Journeys, but again, there are other kinds of programs out there, often within the same agency where you have a New Journeys program that person can attend. Let's see, how do we support the people who are past their early identification and intervention phase? Again, just a great question. And I know I've kind of answered that in various ways. I don't know if, between Kyle, Catherine, Cami, you want to help with that one a little bit? Just, I think, again, we've talked a lot about other programs within the same agency, and some of which actually have a multidisciplinary team like New Journeys, like the PAC teams, for example, in Washington State. Any other thoughts on that in terms of other resources that you all want to add, or common ones that you may send them to sometimes when you've screened folks and realize that they don't meet the criteria?
There is the WISE program. I know that comes along. And as far as the others are concerned, we typically try to look more for other specialty programs that are subset to WISE, but I know that's the one that has been more common.
Yeah, I always think about providers who are trained in CBTP, and so finding them, I think on the Spirit Lab, I think there actually is a link to providers who are trained in CBTP. So I kind of, when I'm thinking about screening, identifying, okay, what are the needs that you could still get met, but maybe not by New Journeys, and how can you kind of put those things together to get all of those needs met, maybe from different agencies, but just really kind of figuring out what is the high priority need, and connecting them to somebody who knows psychosis.
Thank you both. I was trying to respond to someone on the chat here. Great. Any other questions? I'm going to start scanning the chat a little bit more, but as other people have questions, the other thing is, the nice thing about having a capacity to unmute yourselves is that you can do that yourself and ask the question. So we would love to hear from some of you in the audience. We have about a minute or so. So sometimes it takes a lot longer to type versus ask your question. So I also encourage you to do that while we take probably one more question, depending on how long the questions are.
I have a question.
Yes.
Have you already discussed this? I came in a little bit late, but did you talk about how people pay for this insurance, and does the insurance cover it, and do you accept Medicaid?
Yeah, so Medicaid does cover, and there's a specific type of financing arrangement through Medicaid that programs are covered. There are a select number of slots within the teams to take private insurance as well. And I think it just depends on the provider to what extent it's, all of the different elements of New Journeys. Typically, they're just billing based on the specific service that's delivered, that is based on like a CPT code for example, just providing psychotherapy versus kind of the whole array of New Journeys services. Anything else I need to add there, folks who are also in the financing side of things? But the answer to your question is yes, especially for the Medicaid folks, because that's really where a lot of the work nationally has been happening. And private insurance is kind of another big area that people are working on, is like really trying to get sort of it to be covered more by private insurance. And again, it just really depends on the insurance coverage. And again, it's typically for each individual service. And Cami just put in the chat, slots are available for individuals who are unfunded, undocumented, or underinsured too. Thank you, Cami. Great point. Great. Well, y'all, we're running a little over our time. Thank you so much for joining us today. You've got about 15 minutes of just a break before we go to our 11 o'clock breakout sessions. And again, there are 3 different breakout sessions you get to choose from within the virtual gathering platform. So thank you again for joining us, and don't hesitate to reach out. I'll put my email address in the chat if you have any questions. I'm actually responding to a couple of folks in the chat here too. So We'll look forward to seeing you guys for the last hour or so of today. Thanks for joining.